Well,
if you can see me over this, I better stand here so you can see me over that.
thank you very much for the invitation. We're here to talk about an intervention study and how it's benefited patients. I'll just start off with the literature. I think most of you know this. Adverse drug reactions are costing the NHS a lot of money. Primary care incidents, medicines mismanagement, mainly due to inadequate monitoring, are forming a big chunk of the reported incidents, and adverse drug reactions are contributing to the health inequalities. As you can see, the antipsychotic prescribing varies with your social class. So from the literature, you can see there's wide differences in estimation of how many adverse drug reactions there are and how much inappropriate prescribing there is. Some of this depends on definitions, but it's obviously quite a widespread, if uncertain, problem. And we are an intervention because there's a global patient safety challenge. We've only got 4 years to meet it now. And monitored insufficiently is a very important point that we think we can help with. So what we're doing is introducing a checklist, and we're not checking the medicines, we're checking the patients for the possible adverse drug reactions to antipsychotics, mood stabilizers, anti-epileptics, antidepressants and benzodiazepines. And the profile that we've developed has various sections. Those are the headings, the vital signs, observations, the questions, some health promotion, checking on medicines administration, then what do the service users think, and does care planning, prescriber contact need to be changed. So that's what it looks like. If you want to see a copy, I've got some with me. And Karen is going to talk about successfully using this in the home where she's the matron.
Monkstone House is a 41-bedded home made up of mainly clients with specialist dementia needs. Initially, we were asked to take part in a pilot scheme working with Sue and Swansea University to develop the profile, and consequently, we've been now running the profile for the last 5 years. During that time, we have been able to greatly reduce the dose, and in most cases, clients have actually been antipsychotics have been discontinued. It starts with the initial assessment, so when we've used the profile as part of the admission assessment. So when somebody comes into Monkstone House, we go through the profile. As you can see, I think there's a copy on everybody's table, or what we go through, the vital signs, observations, history, that type of thing. It's then reviewed on a monthly process as part of the care plan. We use it in conjunction with the MAR chart. It does take initially a little while to set up, but like I say, we include it in the assessment, in the admission process. Once it's up and running, it doesn't take long to fill in, and we use it with the MAR chart. So as you would fill in the MAR chart, you would fill in the profile. Like sort of the last 5 years, it has made a great difference to our clients. It's improved the well-being of the clients. We've reduced admissions to A&E. We've had a big reduction in fractures. And it's really improved the well-being of the clients, and not only that, it's given the staff the information because they're completing the profile. They've got the evidence, the documentation, which enables them to take part in decision making with the multidisciplinary team. It's also given the staff the confidence with that knowledge and documentation that they have to challenge GPs when they are prescribing these drugs. Obviously, we have got that information in the profile, the document, the information is there, so that you can challenge, that these drugs are not really having the desired effect. And what we have found throughout the 5 years that we've been doing the research is that the advantages of the drug are not as great as the risks. The risks far outweigh. We've had clients that have, by using the profile, identified other health problems like underactive thyroid. By sort of looking at the profile, we've been able to reduce the dosage, the administration times. For example, with risperidone, people come into us and mostly risperidone is prescribed at night. We find that it keeps them awake. We give it now in the morning. That's had a much better effect. And I think where psychotics are useful in the transition period, lots of clients at home are prescribed antipsychotics that are more manageable. I think they can be of benefit in the transition period while they come into a home. But because of all the other adverse effects that they have, mobility, all the other things which are in the information, and obviously I can answer any questions anybody would have afterwards, the actual risks of taking them is not, the benefit is not there, and we have found that during our research with Sil. And as well as it's improved the staff's self-esteem, in that they feel that they are actually contributing and that they are, making a difference to these people's quality of lives. And it has been a huge success in our home.
Well, thank you very much, Karen. I mean, one satisfied customer is a far better. And thank you. That's really helpful. So follow that. Yeah. So to summarise, these are some of the overall benefits of what we've seen. We've reduced antipsychotic prescribing, which is obviously a focus now for Welsh Government. We've got an intervention that works, and we're sort of asking everybody to take it up. So some of the things that we found, and we've worked with care homes, we've also worked with the acute services, and in the acute services we found sort of more acute problems, things like chest pain, which were possibly life-threatening. And this is the trial that we did in care homes, and as you can see, with the profile, we're picking up a lot more problems, but also the professionals in the home are identifying a lot more problems. And we're very thorough, we're very long, and I think that's quite important for research going forward, because, and this is something that the EMA picked up, we don't really know. We know who goes to hospital, but we don't really know who has constipation because we're not asking patients, and some patients are reluctant to mention that. And we pick up that quite often, and I think one of the previous speakers found that it was quite a while down the road that you actually realised that the problem causing the perineal pain was constipation. So we're documenting more thoroughly, and that's important for research too. This is from the trial where we reviewed the case notes, the sort of things that we were finding, and how they were addressed, and how we did reduce prescribing, perhaps not vastly because we didn't have perhaps the time, which is the problem with research, but we also picked up problems which could be actioned. And the study that we've moved on to now is we've been observing the use of the profile, and we've also been interviewing the stakeholders to work out why not everybody is rushing to our door. And so from our observations with 30 patients, we found quite a lot of problems, and most people had some change to care. The new thing about this study was we had a pharmacist review, and the expert pharmacist found a lot more problems. There were only 18 people on antipsychotics and he wanted 17 reviewed. But as Karen said, that's probably what's needed. There are only 13 people, they were either on anti-epileptics or mood stabilizers, and he wanted 11 of them reviewed. He picked up medicines increasing risk of falls, and there were a lot of potential drug reactions. And a lot of these drug interactions weren't clinically important, and Adre was able to tell the pharmacist, look, this patient is not falling, so it doesn't matter. So some of the gains, most people had some change of care. Again, as in the other study, there were people not reporting their pain. When it was reported, the nurses did something about it. We found more people that respiratory problems, people who had shortness of breath, and that got picked up and that all got actioned, so that was good. Risk of falls, modified care plans, and in 17 of the cases the prescribers were contacted by the nurses, but the pharmacist wanted all the prescribers contacted. Then we did some interviews, and our biggest support, the service users all said, you've got to do this. Things could go terribly wrong if you don't. The stakeholders were a very varied group. On the whole, the pharmacists were positive, the GPs were more ambivalent, and the nurses, once they got used to it, got over that initial hurdle, were on the whole positive. So the implications then of what we're doing is that this simple intervention can improve people's lives. It can pick up problems before they get to A&E, which is, as Karen's saying. And also, we've got a huge set of supporting information, and we're also documenting that the medication has been reviewed. And that's going to be important in the view of Dialoid's report, which I'm sure everybody's seen, antipsychotics in care homes, and some of the things the Old People's Commissioner was saying, the Alzheimer's Society, they were very, very keen that antipsychotics should be stopped in care homes. And we think we've got a way of doing that, as Karen has said, really. And the recommendations that the Minister responded last week that is going to be accepted is that the care home inspectorate must document quarterly medication reviews for everybody in a care home on an antipsychotic. And we've got the means to do this. So we hope will get adopted so that this recommendation that Di's worked so hard to get in will actually happen. And as Di says here, we are comprehensive and we are person-centred, because it's a means of feeding back from the patient, from the families, and because the timelines are very short for the report implementation, we are ready to roll. And some people have been doing this for many years. We also fit into some aspects of the NICE guidelines, which practitioners will look at. So what could possibly go wrong? Improvement initiatives these days all seem to have a logic model. What can go wrong? We know what we want to do. We know what we have done in research studies. We have now got to get practitioners on side, not just in the best nursing homes, but in all nursing homes. And it's about people's learning, people's degree of belief. How does this fit in with their prior degree of belief? I mean, early on, consultants saying, well, yes, I can see that people have got a tremor, but what do I do because they're mentally well? If somebody's stable, and none spoke about that, if somebody's stable, what do we do? So that's sort of degree of belief problem that we need to address. Maybe stability isn't everything. So what could go wrong? I mean, what we're trying to look at is prescribing changes, and what can happen is we can stop all medicines, and then the disease can come back. Or we're doing this and we've got resource diversion, so we've got to persuade people. And we're trying to obviously improve. We've got our goals, which are sort of universal goals, and we've got the unintended consequences. So if we stop all medicines, we could bring the disease back, and we don't stop using the profile. We've got a sort of a tail-off period, because we have got the problems of under-medicated illness. For example, when we had pain, and our asthma people, our 4 people with asthma weren't being reviewed, so they were actually under-medicated. And we also have switching. So our unintended consequences could be, there has been a trial on deprescribing, not by us, but it didn't always work. People weren't necessarily better, but the profile would pick that up. And another thing that we've already seen is therapeutic substitution. People stopping antipsychotics, and then they're giving a lot of diazepam, or even in some cases valproate. So a problem could appear in another place, which is why our profile is so comprehensive, because people might be more sedated as their medicines are changed. So what we are is about risk minimisation, so we can capture the unintended consequences as well. And we sort of fit in with the literature here, because we're expanding data collection to pick up the mundane. And other people have found much the same as we have, that if we don't have something thorough, something will crop up in another place. So we feed back to prescribers, we capture their experiences, we're able to give the professionals closest to the nurses, professionals closest to the patients, a voice, which they wouldn't otherwise have, because sometimes GPs come in and they're in a hurry to review, and if we've got something written down, that speeds everything up. And I've found sort of working with nurses, often they lack confidence in their knowledge, because they often have knowledge, but they feel, oh, somebody's too busy to hear me. So if it's there, it's documented, and the inspector can see it. So this is what we're working towards. So it's the nurses and the patients working together, passing to the pharmacist and the prescriber. But there's also, we need to think now about the regulators and the analysts, because we are picking up the data that we need to make informed decisions, improve patient safety, and contribute hopefully to the Wales response to the WHO challenge. Diolch. Diolch I chi am eich amser, and any questions?